Today presenting, we have Trish Casey and Nick Salzman. So Trish has been a paramedic for 20 years. She's been with the STARS program for 5, so you all will learn a lot about STARS today and what their program is and the special needs kiddos. But she helped with the development of that program and has been with them for 5 years. And then she's also in nursing school now. And she's married to a paramedic. I get the pleasure of working with him. So then we have Nick Salzman. He's been a paramedic for 15 years, and he's been with the STARS program now for 10 months. Do you have any posters left, Nick?
I still have posters left, so please come take them from me.
Yes.
I failed if I take any back to St. Louis.
Yes. There's a really cute poster, so they'll talk to you all about it, but obviously trach care and pediatrics can save lives. And so it's a poster that kind of talks about, it has a cute kid with a trach on it, and says something to the extent of help me if I'm having trouble breathing, change my trach out. So it's a good thing to put in your break room, you know, just for more awareness, so folks get more comfortable with that trach care. But please give us a warm welcome for Trish and Nick.
Thank you. I'm such a walker when I talk, so I have to figure out where the blinding light is. Because I'll hit myself with it until I get flutters in my eyes. I think did the raffle just end a little bit ago? Okay, that's what I assumed. So I'm you'll be able to hear me better in just a second. So how many of you, first of all, how many of you attended the first lecture? Awesome. So this will, just to clarify a little bit the difference between the two, if you attended the first lecture, that was really focused on the special healthcare needs of children with complex medical needs and how atypical they are and how unique their needs can be in general. So that was a more medical type special needs lecture that mentioned STARS only in that the fact that we make these individualized emergency care plans for children. This lecture, One Kid Counts, is going to be more of a description of the history of STARS, where we began, why we began, what we uncovered in the process, and where we're going. So hopefully this can help you guys get some more insight on what the STARS program is if you aren't familiar with it. And our whole goal is growth and to improve emergency care for pediatric patients with complex medical needs. So we always want more people to join our cause. So One Kid Counts actually is our hashtag. It's kind of our motto, our mantra. You'll see it everywhere on social media. We're starting to get a following with the One Kid Counts. The hospital even finally adopted it and accepted the fact that we have our own. And that comes with kind of a neat story. Actually, I'm also the chair for the pediatric subcommittee for the state of Missouri, for the state advisory council. And I've been attending those meetings for quite a while before I was ever chair. And when STARS was in its infancy, I was actually arguing, believe it or not, I can be argumentative. I've been told I'm persistent, not pushy. I'm like, okay, thank you. Kind of, you know, advocating for these kids. And something that we talk a lot about is tracheostomies. And you'll hear me talk about it in every lecture I give. That's why we made the poster, because that's where we actually see that significant number of neurological devastation and death, and I'm going to show you it there. But this one particular person that I was up against, kind of advocating for the need for this throughout the state, the need for this big movement. I was talking about the kids who died in trachs, and she said, wow, you know, you guys must have a lot of trach kids in St. Louis because we've only lost one. And I just had to pause. I'm like, you know, only one? And she said, yeah. I'm like, first of all, I know that's not true. That's the only one you know about. And second of all, I challenge you to go in front of those parents and say, hey, we only lost one, and see how they take that, because one kid counts in St. Louis. So that's kind of where that stuck. And we started using it, and now that's like I said, our hashtag. So, and our motto, every single one to us matters. We always have to have a disclaimer slide, right? What I tell everyone, it's like a formality because especially for stars, because we lose money like crazy. We don't charge for what we do. We're constantly pouring money in our program, so no, I have no commercial supporters. As far as my photos go, yes, it's very few of them are public access photos. The majority, if not all of the photos I use in any of my presentations are my kids. And that's intentional because I like to bring attention to my kids. I like to tell their stories because they matter, and it's fun to bring their personalities out into the presentations. So STARS is an acronym for Special Needs Tracking and Awareness Response System, and it's a multifaceted system that we're going to get more into here as the presentation goes along. But it's so hard sometimes to sit here and say, describe STARS. There's so much to STARS, but yet a photo speak 1,000 words, right? So this is one of my favorite slides to put up at the beginning of almost every presentation that I give. And as we keep formalizing our program, the one thing that I don't ever want to lose is the community aspect of the program. This right here, getting the medics with the kids, getting this face-to-face meeting, getting to know these kids prior to that emergency ever taking place. And the funny thing is when I created STARS 5 years ago, I knew this was a part of the program that had to be included. But my reasoning at that time was that I didn't want any child to ever fear men and women in uniform. I wanted them to know that we were the helpers, we were safe, we were fun, we were the good guys. But what I learned really quickly is that after 5 full years of doing this, I have yet to meet one child who had any hesitation or anxiety whatsoever towards men in uniform. We're like real life Paw Patrol coming to their house, or then coming to the firehouse. They're like, this is the best thing ever. I mean, even our nonverbal kids are like, oh, yeah, fire trucks, lights. I mean, we're heroes. So what I discovered quickly is that it was the opposite. Like, strike that, flip it. I had to get the paramedics and the firefighters comfortable around the kids. It wasn't so much that they cared, but there was an anxiety level. Like, how do I approach them? Can I talk to them? Do they hear? Do they see? Is it okay to touch their equipment? Can I touch them? Will that upset them? Will it hurt them? Can I move them? And my answer is always yes. You can touch all of them. They love to play. They love to be active. And then I say, well, my disclaimer is that you'll hurt him. He'll break. But we'll let you know which ones will break. It's rare. So very few of them are that fragile. But just getting to know truly what that baseline is and that establishing that comfort level, I can't even put into words how much that benefits when the time comes for that emergency. If it's a kid they've met and they know that they've deviated from what is normal and how much they've deviated, it's amazing to see the sense of urgency increase, to see the sense of trust in the parents who previously would have never considered 911 as an option because they kind of have it in their head that they're not going to know how to handle their child. They don't want to go to the closest hospital. They just rather drive fast to the hospital. Seeing that trust develop has been amazing. So let's go back to the beginning. So how this all began, that would take a full hour, and I talk a lot. I have a daughter who has a neurological a syndrome and a mild bleeding disorder, and my dad had an adult onset muscular dystrophy and ended up with a trach and vent and G-tube. And I worked in critical care and ICU. I had all these factors that made me comfortable with this world, personally and professionally. And then I always loved pediatrics. We also, at Rock Township, where my last full-time career was on the ambulance, we started to have a few frequent flyers that were kids. There were 2 of them, in fact, who had complex medical needs, and they were a struggle. We would bring people in for training. We would do training on these kids to try to fix it. 6 months later, we would do our part-time hiring, have a whole new slew of people who would run this call. The training was now useless because we had new people there, et cetera, et cetera. So long story short, I knew something had to be done, and I knew I had interest in fixing this problem. I had firsthand experience with being fearful, and I knew it was something I was interested in and the community I was passionate about. We had new hires coming, and I was going to recreate our orientation process. And I was reading in our manual, like one of the first pages of our protocol book, had a clause in there that said that we should be familiar with the equipment and special needs of children with complex medical needs in the community and have a plan. I'm like, wow, that's been in there probably for 20 plus years as a formality, because we sure as heck don't do that. So then I Googled special needs pediatrics, and I came up with the emergency information form, which you guys can Google it, look at it. Something that the American Academy of Emergency Physicians and the AAP put together to fix this whole problem in the 90s. I'm like, this form is great. It's got decent information. Unfortunately, it's handwritten in most cases, and it's not really appropriate for the pre-hospital. It doesn't take into consideration our scope. So we took the information from that form. I created the STARS form, put color on it. So I'm like, I need color at 2 o'clock in the morning. Simplified it, pulled off the information we didn't need, threw our logo on it, and I called dispatch. And I said, hey, if we number these kids, could you relay that number to the crew if it comes out? I don't want to just flag their house. I want the parents to be able to call and say, this is, they were the rock stars originally, rock star 1 or rock star 2. And I was, oh yeah, no problem. Well, that was easy. Now let's do training on them. Let's have this in a binder in the truck, and let's really do it. Everybody that does these things and they just quit, and I'm really going to do this. So my chief said, make me a proposal. So I made Operation Rock Stars. That's the cover from the original proposal. And the board passed it, and STARS began. So that's the picture of one of our first interviews with Nathaniel. He's in one of my last lectures a lot. He has an incredibly complex airway. And that was actually his very first day coming out. His mom took that picture of Andrew and I collecting his information, and that's all it was. The kids came up to the ambulance district, or we went to their house, and we filled out this form ourselves as paramedics about risks and history and their baseline findings, and we did training amongst ourselves, and STARS was born. And that's all I ever intended STARS to be. I didn't have plans to leave Rock Township. I had a decent pension plan there. I was a lieutenant. Things were comfortable, but it exploded because we had uncovered a solution to a problem that others had been trying to solve since the 90s. And why it worked is that it made sense. It had to come from the field. Every other program I've ever looked at to this day, I still get phone calls from across the nation from different pediatric hospitals who've attempted to do what we've done. They said, what are you doing differently? And when I go, take me back to day one, how you started, they all started from the hospital out. They all lacked the understanding of the pre-hospital environment, and they all wanted to wait for a program to be perfect to ever launch. I don't know when STARS will ever be perfect. It's an imperfect system. It probably will be for quite a while, but we had to accept it because kids were dying and something had to happen. We had put trust in field providers to create these plans. We had eventually started to involve EMS medical directors and bring the pediatric hospitals out to do education to make sure that all the plans were written with an EMS scope. We took that into consideration. If a kid had a special order, we made sure that EMS medical directors approved it. And that was something that none of these other systems had ever taken into consideration. And none of those other systems had taken into consideration the fact that all of this information and training had to be in the hands of first responders prior to this accident or incident, this inevitable incident, ever taking place, or the whole thing was going to fall apart. There's no use in handing someone a sheet of emergency information that includes syndromes, names of equipment that they've never ever seen or heard of. Because in a high acuity situation, I don't know about you guys, but if I'm worrying about a kid in a peri-arrest situation, I'm not going to pause and step back as the only ALS provider and start flipping through stuff and then Googling. It doesn't work that way. Let's see. Oh, clickers and me. Not breaking. See, now my fear is I click it 5 times. Now we're going to skip like towards 20 slides. There we go. So what else we uncovered is that these complex kids are at risk. We kind of knew it. The AAP said it in 1999. They came out and said that pediatric patients with complex medical needs have suffered negative outcomes in emergency settings. They made that statement when they made the emergency information form. But they're really, really, really at risk. And not only are they at risk, the problem is growing. The education hasn't improved, the systems haven't improved. Their out of hospital resources have lessened, they've declined with the state of healthcare in our country, but they're exploding. And no one has a good grasp of that number, but we're trying to find it. And in fact, we did a poster for the AAP last year, and I'm like, I need to have some numbers. Like what's been the increase of tracheostomies we've done, especially in the NICU from 2017 to 2018, when we came up with was a 41% increase in trachs performed. That is huge. And I can guarantee you that number has increased from 18 to 19. We haven't run those yet. We do know that these fragile children are coming home all the time with equipment and syndromes that not only EMS, but community hospitals are not prepared to handle. And that while we're teaching these parents in the hospital still, we're telling them that if this is an emergency, hang up and call 911. And they've left out some pretty important people in that equation because no one up until now has actually taken the time to prepare EMS. I like standing on this side. I think over here. My clicker doesn't work. So have we failed these kids? Yeah. I'm going to say yes, without a doubt, we have failed these kids. And actually, my medical director, who's the best medical director ever, because he's not afraid of politics and not afraid to say if it's the right thing to do, just do it. He'll come out and say, yes, we failed these kids. And this is coming, I'm saying this from a pediatric hospital standpoint, we failed them. And this is an example of a timeline just to show how. So this is my friend Lavender. She was St. Louis City Star 22 originally. And that's a picture of her in our TCU, just a week prior to discharge. And her mom just happens to be a costume designer. So every day that Lavender's in the hospital, she's in a different themed costume. Like she's a mermaid sometimes, she's all kinds of fun things. But this day she was Snow White. So they took the opportunity to take a picture of Snow White and the 7 dwarves, AKA residents, nurses, RTs. So when I saw this picture, I called mom right away and said, hey, I need a media release. I want to use this picture because what I saw was not necessarily a great photo op. What I saw was the fact that this is a very fragile child on the ventilator who tends to have atypical seizures and heart rate issues. And before anyone even pushes a code button, since she's on a monitor floor, this comes flooding into the room to save her if she does anything atypical. Nothing changed from that picture. In fact, that's like a day later of her passing her car seat test, which is not significantly destatting after 40 minutes in a car seat. And then we said, bye, see you, good luck. And we relied on the fact that her mom would hopefully be able to stay awake 24 hours a day to watch her because she was one of our many, many vent kids who went home to St. Louis City where we have a really difficult time filling nursing hours. And she didn't have any nurses that accepted her home care for the first week. So mom with another child in the home and dad who works and travels was supposed to be responsible for providing this level of care because that's what we decided in the hospital she needs to stay alive at home. And again, with the, hey, call 911, they'll help you out. Good luck. We also uncovered some field deficits. So I think my clicker's working in this step over here. So when I started at Glennon, eventually the program transitioned into Glennon. It went crazy. We had covered that solution. I went to Glennon full time just to run this program. I started trying to figure out who the sickest of the sick were, and I wanted to meet the people in the NICU and the PICU and our complex care clinic folks. And I started walking around the hospital friendly, introducing myself, and some people didn't like me a whole lot when I introduced myself as a paramedic or identified myself as a paramedic. Respiratory therapy in the NICU especially, because they were the ones who had seen a lot of these losses of these children they had worked so hard to save. In fact, they had just recently had a death and a neurological devastation within 2 months, both from EMS failing to act on a plug. Both, unfortunately, were cases where parents said, hey, we need to do a trach change, and I have the documentation, it's horrible, I'm not letting the paramedics, they weren't trained, and the paramedics said, no, he's crashed, we gotta go. We can't pull an airway, there was no training there. So these kids suffered, and one of the things one of them actually asked me was, oh, you're a paramedic, aren't you supposed to be an airway expert? And I was like, not bad, I think I'm pretty good. She's like, you can't even handle a trach? And I was like, I can handle a trach, I'm really comfortable with trachs. But then I started thinking about it more and more as I went up the day, and I'm like, I don't remember if I had trach training in paramedic school. I had a family member who was trach. I've been doing trach changes. I'm very comfortable with trachs. That was from personal experience in working in the hospital. Did I have trach training? Like, I don't think I did. So we started polling people. And what we came up with after polling hundreds of paramedics in the St. Louis area was that 62% that said no. We repeated that survey in 2018 nationally with a webinar that I did with Dr. Antevi from Pediatric Emergency Standards, and this was mixed providers of physicians, nurses, and paramedics, and 60% came back saying, no, never had anything like that. And I was like, well, who's to blame? We can't blame people who were never taught. In fact, people who thought that maybe if I pull a trach, that's the worst thing I could do. So we knew we had a lot to work on. Just work. Staying over here. All right. So this is something we did for the AAP, also for our poster. We did, we tried to show that we had corrected or improved these incidents of trach injury and death after STARS kicked off in 2015 formally with formal training to the masses. And not only were we able to show that extreme reduction in poor outcomes, we also showed a massive increase in calls themselves. So you can see that the calls, the 911 calls generated for pediatric patients with trachs for respiratory distress drastically increased in numbers. What we also learned after I came to Glennon is that this wasn't going to work broad scale. The whole model of having EMS going out and doing these plans themselves and maintaining these plans and doing the education, we weren't going to be able to keep it up. I got buried fast. There were a lot of stars. Holy cow! And everybody wanted to be a star and have their patients be a star and have their children be a star. And what we also learned was maybe not everybody needs to be a star. I'm a bleeding heart type, and I have a really hard time telling people no. But we started out doing, any kid who had any complex medical history or any medical history, rather, whatsoever, could be in the program. But then we found we didn't really know what complex was. There were kids that were out there that were so sick and so unique that maybe this is the community you really need to focus on. Those really, really scary kids whose lives are absolutely at risk without this plan. This is Helen, who was in the previous picture. This is an example of how complex these plans and how intricate these plans can be. Not only did we realize that we really need to focus in on this community who really deviates from standard protocol, we really need to get a formal process in place with not just EMS committee. So as you can see, Kellen here, he's a kid who has a G-tube in place. He's ventilator dependent full time. He sees this multiple times a day. He's got a vagus nerve stimulator in place, which I don't know if you guys aren't familiar with that, but he just has a magnet that we swipe when he's in a status epilepticus. He's on a ketogenic diet. His team doesn't want his blood sugar treated unless it's less than 40, and he has a modified DNR. So this is a kid that has so much going on. You know, what we also learned was that this was going to truly take a dedicated team. I couldn't handle this on my own anymore. We needed my medical director to be available to us. I needed another full-time person to help me, which is when Nick came on. And that the database was going to have to come into play. No longer could we maintain this program on paper plans. The problem with paper is that it becomes quickly outdated. We had version control issues when we have multiple plans out there. It's impossible to guarantee that everybody who has access to this plan has the most up-to-date plan. And we have our kids traveling constantly. So where we started out with 20 or so children, now we have 600 between 2 states, and they're all over the place. We needed a database. We needed a centralized location for this information. We needed a constellation of sorts to bring this all together. So the database was built that has an app along with it to where you can access any STARS plan, no matter where they are. We knew that we needed those metrics in place, something that we struggled with as we seek grant funding and finally obtained it and are trying to get more, is that everybody wants numbers. Those anecdotal stories are only so much. And there is no registry for these children anywhere in our nation. These incidents that take place, these deficits that take place, doesn't exist. Something that there's a lot of interest in as well for these kids is disaster planning. I get a lot of inquiries for disasters because there is no registry anywhere that exists that shows you where these children reside. It's just been a very loose process. Ameren list, sorry, I love Ameren, I want to knock on anyone who, I'm knocking them, but it doesn't do anything for these kids. You know, I get that a lot. Oh, we're on the Ameren list for power outage. I'm like, it's not going to do anything for you. I can speak from experience. So we do have areas where the fire department has really taken a lot of ownership of their program, and they actually have plans to get generators out to kids or help parents set up generators for their kids on vents for prolonged, power outage. So we learned that everything's going to have to tie into this database to keep it organized, to keep it up to date, and to keep us relevant. We also learned that communication was key. We've had some fails. To keep these kids safe, we truly need everybody who is going to be involved in an emergency with these kids to have access to this emergency information, and that included everybody on this list. We've since actually just recently moved into the special school district to do more training with school nurses after we had an unnecessary death in a school. But just when we think that we've gotten there and we've solved this, someone falls through the cracks. Something else that we've been trying to prove, which doesn't exist, is when these kids are dying out of the hospital or returning and having a 911 call within 48 hours of discharge, where those high-risk kids are, if there's something in common with these kids. And what we've started to, small scale, our preliminary numbers are showing that these are our big risk factors, those unfilled nursing hours, eyes off the kids. So a lot of our, actually I only have one out of hospital unexpected death where there was a home health nurse on scene. Unfortunately, that was an outlier. She caused it. The kid had decannulated, mom was driving, and she kept just silencing alarms, saying that the pulse ox just wasn't picking up, he was cold. Mom kept saying, is everything okay? Oh yeah, it's just cold. Silence. Silence, silence. Every other one was an eyes off during sleep. So that's why I added the inexperienced home health. We have the being mainstreamed in school without a personal specialty trained nurse. Nick just did his first training with our onboarding nurses for special school district for St. Louis County, and we're hoping to have a partnership moving forward with them. And then home environment. I think the majority of you are all pre-hospital workers, so you probably know what I'm talking about here. We have people with just low access to resources. And then location, that comes into play when we get into the rural areas where they just don't have quick access. So I'm going to let Nick take over a little bit for the where we're going, since he's just joined us.
I can try to use my big boy voice. You guys can hear me okay in the back? All right, we'll try that, and if that fails, I'll. So I think, coming out of that last slide, real quick, home location will also feeds into that. It's not necessarily part of it, but is also something else I would add to this list is poor communication between specialists. So these kids have a lot of complex care. I mean, you saw Mr. Kellen's form, and he certainly is probably one of our most complicated kids. But most kids in our program see multiple specialists, or if they only see one specialty, they're still like a super severe kid within that specialty. And sometimes we can have that really poor communication within our healthcare system where one side saying, do this, change these medications, and then the primary care is not catching it, or something else is going on over here. And if everybody's not talking to each other, unfortunately, we can have some really poor outcomes from that. You can't just change neuro doses without affecting another system in the body. So I would add that as something else. And so I think that kind of helps play into part of what we're trying to do here and why the system is working. And that is that we are trying to tie everyone together, from that kid's specialty hospital to their home environment and to the 911 providers who are going to go out and take care of that kid. And so this is kind of a workflow of how we build a STARS form, how we get a kid, and after we receive them, the process that we go through. And so we'll get the referral. Referrals come in many ways, shapes, and forms. In the early days, we used to just meet the kids as ambulance providers at, county fairs or festivals or wherever we were out doing PR for our district, and then people would approach us, or else people would be taking their kids to these events, and all of a sudden we'd be like, wow, like, I really want to know about this kid over here and what's going on with him, because that's something I need to know about in my community. So I would say that was the simplest form of where referrals started. It has gotten a bit more complicated since then. Certainly, if you're still encountering those kids, that is an excellent way to get your providers in touch with their community. But where we get the majority of our referrals now that we work within the pediatric specialty hospitals, is from clinics within the pediatric specialty hospitals. And so we have developed those relationships with our complex needs clinics or with our respiratory staff who can say like, hey, we got this kid coming out, you guys should know about him. And even for services further out, I was having a discussion with one of the practitioners in here earlier. A good place to talk is to your emergency department, because they're also seeing these kids too, right? So ask them, where, do you have complex needs kids coming in? Where are you shipping them out to? Are they aware? Have they tried to talk to us as a 911 provider? How can we get to meet these kids that are in our community? Also through your schools, as we discussed with school nursing, that is a great place to find these kids before they have an emergency, right? And kind of start pre-gaming their situation. So we'll take in the referral. We vet whether we think the kid should be in our program, and we'll discuss that a little bit more in a slide. And that I hate to give it away with a spoiler, but there is no tried and true formula yet. But we'll talk about a lot of the factors that come into that. We actually write the plans, for me and Trish do, and that surprises a lot of people, especially in the hospital world, where they're like, 2 paramedics. But we find that that was the way it had to be. We've read those specialty letters that come home from the specialists, and it's just not appropriate for EMS, and they don't always know what EMS can do. And so, it's great that they can say, oh, we have this metabolic kid. If they get sick at all, please just give them D 9.5, half normal saline with potassium runs, and I would really like you to toss a little bicarb in there too. And we're like, I think our ED doesn't even carry that at Glennon, and I don't really know where we're going to get that from. So how about let's talk about an alternative solution? And so it allows us to catch a lot of problems before they get out to the field, and we can kind of help connect those specialists to protocols that EMS can follow and adapt to. We do still do a specialty review, especially for anything that, any order that a specialist is going to write for their kid that is outside the typical norms for an EMS provider. So if they're going to say, you know what, this kid doesn't respond well to benzos, we already know that, I want them to receive a dose of this from the parents at home, or else if they want to write in, I think an excellent and a very simple example is our cardiac kids, where, they're allowed to say, they're like, you know what, this kid should normally sat between 75 and 85%, or this kid should always be over 85%. And that seems like a really simple thing to write into a plan, right? Like we're just playing around with what vital signs are typical for this kid. But if you think about your protocols and how they are probably written right now, and if you took your brand newest paramedic and let them go run that kid for the day, and he's going to show up and say, oh, this kid's sats are 80. I must give them high flow oxygen by non-rebreather because I, passed national registry last week and that's what they told me how to do. Well, that might not be very appropriate for that kid. And so by including the specialist, we get specific parameters for the kids, specific instructions for the kids. And then we consider that plan kind of good to come out of the hospital. But one of this key step is really the key difference that's allowing us to advance this program. And that is having the EMS medical directors sign off on the plans. Within the database, your medical directors, whenever we write a draft, we say, you know what, this plan is good to go. I got the specialist to look over it. I'm ready for EMS to follow this. I hit save. It sends an email to that medical director. They go in, they vet the plan, and they have an approve button at the top. And until they hit that approve button, that plan is not viable for the EMS providers underneath them. So they are able to specifically check, okay, the specialist said, this sodium bicarb, what is that talking about? I want to talk about this. Or they're saying like, oh, they want this kid's O2 sats to be 75 to 85%. That's reasonable. I agree with that plan. And they hit approve. And so at that point, and only at that point, does that plan become viewable and viable for the EMS providers working underneath them. And so that plan can be considered the appropriate thing to do for that patient. What it's allowing us to do is write custom-made protocols for these kids, right? So these kids who don't fall into the cookie cutter protocols that exist for the 90% of the population, well, now we can write custom-made for them. And it got approved by that medical director. So that's allowing us to circumvent some problems that these kids otherwise would have had. And then that plan is now live, and then we have to include training with it. And especially our kids who are atypical or high risk, like our trach patients, like we want in-person training as quickly as possible to those providers that take care of that kid in that community. We also know that we have to keep ongoing training going on. This is really low frequency, high risk stuff, right? And just like in surgery and in airplanes where they talk about how you just have to drill and you have to train, we know that every 6 months to a year, we have to get back out there and be like, okay, trachs again. And I can't wait until I walk into a room someday and I say trach training and everybody like rolls their eyes, and that'll be a great success for me, right? Like we finally made it. We finally got through to everybody. But we have to keep the training up for these kids. This is atypical stuff. Sometimes we hear that, well, if we just improve the curriculum and we train people completely to the nines how to deal with these kids, well, these kids are so complicated. Like there's doctors who specialize in their subspecialties, right? And so if all of this could hold all this information in our brains, first of all, that'd be awesome. Second of all, you should probably go become a PIM tomorrow. And then it's just really complex stuff, right? And so we have to constantly address it and follow up on it. All right, so that's what we're focusing on being. It's just a complete and true system for these kids. We know that we need that database. We need a centralized point where we can control all the information, everybody has access, and everything you reach at that point, is legit. You're not looking at a paper form and you're like, is this 6 months old or 6 years old? I don't really know where this came from. So I like to give a good example. Our kids change all the time. And so let's say one of them, their medication dosage changed right now. Just saw this healthcare provider, specialist said, double his dose of blah, blah, blah. And they say, Nick, we doubled his dose. And so I'm going to go in, I can log in on my phone right now. I could double his dose of blah, blah, blah. I would hit save. And in 10 seconds, when the tones dropped on your crew and they left the station to go run on that call and they pull up that kid's form in the database, it is the most up to date. That medication dosage is where it's supposed to be. It takes a lot of the work out of it. We know that we depend on our people who work with us from the EMS districts, but we also acknowledge often that's a volunteer job. Sometimes it's a voluntold job. And so people, it's hard on them, and it's that much harder on my coordinators if we make the system hard for them out there. So that's part of why we're trying to use some leverage technology to make the system work better for everybody and to make it easier for the people who are helping us help the kids. We are trying to do more webinar trainings. I wish I could come out every day and talk to everybody in person every single day, but that is just a little bit unfeasible. So we certainly try to get out whenever we can in person, but we also have started developing a lot more online webinar trainings. just so we can at least hit a wide swath of people. It's kind of interesting. We did another webinar over emergency trach care, and we just posted it online. I have it up on our YouTube account, and then we had a online webinar system where people could do it for CEUs. And somehow, some way, a fire department in Virginia got a hold of it. And the next thing you know, I got 37 people from Virginia taking our webinar course and sending me feedback and this and that. And so I would really like to see that take off. Unfortunately, we cannot issue CEUs for everybody beyond Missouri and Illinois at this time. But as far as getting that information out there into the world, and then, we'll work on CAPC and all that stuff, because I certainly know people need carrots for their time, but we just want the information out there so that kids can get better education and treatment here. We've started doing more quarterly meetings so we can include all those extra stakeholders and players who work with us on this program. So that's open, to coordinators, medical directors. We also broadcast that. I know the last thing in this world that people have time for is one more meeting, and I know that even more now that I work inside of a hospital instead of outside of one. But meetings are life, and so we want to simplify. We want the ability to get people the information to people in real time and have them participate via web meetings. Trish works very hard on the representation at the regional and state level, where we attend, East Central for us, and then I also am the person from Cardinal Glennon who goes to the CMO meetings, and then Trish represents the program at the state level. And then continuing to try and hit paramedic programs. I'm sure we all kind of feel this at some point in EMS, like, if only I could go back to school and learn what I know now and kind of like skip over like some of those things that maybe weren't as useful. Backboarding, I mean, I just now, I didn't know that for a lot of years, but really would have helped out, right? And so, let's hit these kids when they're still coming through school. Let's hit these medics as they come through that first time and teach them the right way the first time, so they don't have to constantly have that, which way did it change? Which way did it go? What are we doing today? Are we pushing beryllium again yet? And so we can continue to develop that way, right? And then we do kind of symposiums is just a fancy way of saying bigger training events that we do, which is really focused, we want to get as many people in the room. Now that's only because it's convenient. I have no problems. I'll come out and teach 3 people in an ambulance bay sitting next to a broke down transmission. I got no problems teaching people at any point. I love the sound of my own voice. So, but we try to do these symposiums so we can hit large groups of people all at the same time too. And one of the important things that comes from symposiums is, as much as I love teaching EMS, it also allows us to incorporate some other members of the healthcare community. They often tend to be at those events, and so that helps us tie in nursing and doctors and so on and so forth. All right, and so as part of our continued effort to move and spread, we do also have this poster. You guys saw the graph from it earlier, but this was presented at the AAP last year. And so this is just another sign of our efforts to try and get this information out. And it's also kind of indicative of that problem Trish was describing, where like we know we are making a difference. We know we are moving the needle, and we have anecdotal stories, but you have to have numbers, and especially in the grant-driven world, you have to be able to prove that you are making a difference. So this is what we are today, currently metrics. This is numbers I pulled at the beginning of this week. So this is, keep in mind that this is our electronic database. So we know we have more stars than that, because when we started in Missouri, as Trish described, it was a community project. It was like almost like a franchise, right? Like, hey, we at Rock Township figured out this system. It kind of worked for us. Here you guys go. Please run with it. And so we have lots of areas in Missouri where they have already put stars in, and they track it in their own community, and they're still doing their system. And I thank all or everybody who does that. And it's just kind of our thing where we're saying, and that is what it was, but as we evolve, as we grow this program into the better product that it needs to be, we are going to transition towards that electronic database. And so that's where these come from. So we know it's kind of a funny thing where I can't tell you the exact number of stars we have, right? Like, because I have Missouri districts who, when the last time we talked to them, they had 10, but for all I know, they have 25 right now or 30. And it's not until I go to put a kid in from the Glennon side where I'm like, hey, so-and-so county, like, I got a new kid for you. What number do you have? I need to assign this number. And they're like, oh, we're up to 488. I haven't run into that yet. Don't quote me on that. So, but you get the idea that there are kids that we don't fully know about, and that's another reason why we really want to get everybody back into the electronic database, so that we can track everybody. It's also kind of safer for all the kids. So if you think about your service right now where you are, and let's say you have the binder system, and you go out and get dispatched on a STARS call. If it's one of your kids, that's great. You're like, oh, number 7 again, they called last week. I got this, I'll read it just in case, right? But let's say it's the next county over. You got star number 7 from the next county over who just came shopping in your district for the day. And dispatch is like, you have next county over's star number 7. Congratulations on your 911 call, and if you're not calling in sick today, please go help this child who really needs your help. And so you're gonna be like, that's not in my binder at all. This is just a regular 911 call. So if we're gonna take all the time and all the effort to try and make our community safer for these kids, let's make them safer for them everywhere. And so by being on the database, you have access to all stars. So you have that kid from next door, you're like, okay, I'm not familiar with that kid. Pull him up in the database on your way to the call. You have his information, his emergencies, his anticipated emergencies, the plan to treat him, what you should do with him. It's normal vitals. So it's another great advantage of the database. So like I said, I digress mildly. Here are your metrics. So currently 394 active records in the system. You can see the numbers. We've got 12 awaiting just MD approval, 54 sitting in draft plan, 37 archived. Plans get archived for a couple of different reasons. Either the kid is graduated out, they no longer needed to be in the program, they've moved out of our service area and we can just no longer support them, or unfortunately they are deceased. And so you can see my archive breakdown, 11 of those are deceased and 26 have graduated, moved on, or we lost contact with. So a total of 497 records currently. You can see the geographical breakdown. Like I said, I feel like those Missouri numbers are significantly higher. I know they're higher by at least, I can tell you 150 for sure, as I work with different services that we're working on getting into the database. And then the 81 in Illinois. One of the few things, I never thought I'd say this in my life coming from Texas, but Illinois has a few things that make life a little bit easier. And one of it is the regulatory structure of their EMS. The way it worked out is that we just always controlled the numbers for EMS, and that's why I can give you very specific stats on Illinois, because we've always controlled the numbering process on that side of the river. And then we have our one Kansas star. You can see number of users. So I have 1,136 unique users on the database. I've had 66 logins so far in the third quarter, but as we all check our watches, that's actually only 1 month as of today. So I included the second quarter, we had 126 logins. And then the second, the health care plans for the kids and the education with, or the health care plans for the kids is our primary goal, but education really follows hand in hand with that. And so I like to include our stats for our education, where we're trying to get out there, teach people, issue the CEUs. Like I said, to a certain extent, I just want people to learn. I have YouTube videos. I guess I could put the views up on that. I have no idea who else watched that. But the idea that we just want the information disseminated to this world in whatever way that takes shape. I'll gladly issue CEUs for it if you want to come take one of my classes, but however we get the knowledge out there works. So as I said, we kind of have a little bit tighter control on the Illinois side, so some cool things when we're talking about metrics and controlling our data and what we're going to do with our data. I can map all of our stars on that side. Unfortunately, I can only do that for about half of our stars on the Missouri side. So it's one of those things as we continue to grow and we capture that information. At first, it just seems like a fancy parlor trick, but I think especially as we talk about incorporating the flight services and even your services, in your areas where you want to be like, where are the kids that I take care of in my service region? And so that will very quickly allow you to extrapolate that data to real time, helping you know where the kids are and how to take care of them. And so that leads us to the classic question of who's a star. It is a very hard question to answer sometimes, but I think probably just because of background, it's the easiest for Trish to address that.
Oh, well, in fact, this is a very difficult thing to define. It's something we get asked a lot. Give me that list. The hospital always with that list. Who fits in your program? And I'm like, well, a lot of that depends on their access to care, location, the type of system that they reside in, and how atypical they are within their syndrome. We take traits and events no matter what. That's an automatic in. Cardiac history is interesting because you can get some kids with some incredibly scary looking syndromes and surgical history that are repaired. And actually, once they're fully repaired, if their pump system is back to normal, they really don't deviate very much from typical EMS protocols. That's really kind of what it comes down to. We want those kids who deviate from the normal emergency care protocol. Seizure patients, that became hard. Seizures are common. Fortunately for these kids, that's the second most common pediatric call that EMS runs nationally, consistently, every year for the last 10 years, is seizures for pediatric patients. And EMS is pretty darn good at treating seizures. What we want are the kids with those atypical presentations that EMS misses, those kids that EMS brings in, and not just EMS, they're coming from community hospitals, from flight systems, and like, oh, they're post-ictal or they're lethargic. No, they're full-blown actively seizing, but that's getting missed. We want those status epilepticus prone kids and the kids with atypical treatments, like the ketogenic diet and the vagus nerve stimulator and the new CBD cannabis treatments. The metabolic and mitochondrial kids, those fall into that atypical treatment plan. Those kids are the kids that our attendings at Cardinal Glennon and Children's are not comfortable taking care of. They immediately want to talk to the geneticist and start treating them. And those that have those emergency medications for emergencies, of course for emergencies, emergency medications within the home, such as clotting factor for our severe hemophilia patients, and emergency steroids for our adrenal insufficiency kids. We did actually pass legislation in our state where EMS can legally provide these medications. How many of you guys knew that? Awesome. I'm glad some, because the majority is like, I have no idea. And that's something that I was critical of that. I was like, kudos, wonderful, I'm so glad you did that. But unfortunately, the message did not get disseminated. Plus, that legislation still did not take control from medical directors, which I think is a good thing. But EMS is still like, well, what does that mean? So I can legally give this medication, but my medical director still needs to say yes. What did that really change for me? And do I really understand it? So we still do believe that those kids should be in STARS. Something when we have pediatric hospitals from around the nation contact us and they want to duplicate our program, I get excited to talk to them, and I do, but a lot of them have a hard time implementing. I think that they're still looking for an easy button. They still want a form, just a plan they can send out there and let go. And unfortunately, there isn't one. It doesn't exist. It's going to take a dedicated team, a formal database, lots of education to ever fix this problem. We're going to have to continue to identify who those high-risk kids are, provide that education, and do it in a proactive manner instead of reactive manner. We have to prepare everybody as a part of the care team for these kids, and then share that information with all. We have pushed the barriers of HIPAA like crazy. HIPAA was never designed to withhold emergency medical information. Do you mind plugging this in? Okay, got a low battery message. HIPAA has done more harm for these kids than good. And this is a voluntary program. It is limited emergency medical information, and we tell parents, your information is going everywhere. And I actually had a mom say, you can post his face and information on the side of your ambulance and drive all over the city as long as he stays safe. That's what we care about. So we've got to continue sharing this information with those who need it. And that's example, my friend Nathan, he's no longer with us. He passed away, unfortunately. It wasn't from a field accident, though. He didn't suffer from an unnecessary, an unnecessary preventable death.
But when we discovered how rural Nathan was, just how far away he was and how long it was going to take for him to have ALS care, that was the first kid that we incorporated a flight plan with. And we did it successfully, and we've been doing it since. Do you want to take this?
Cool. So that's kind of where we started, where we've been. So let's talk a little bit about where we're headed. As Trish kind of touched on the previous lecture, and a lot of you heard, should EMS be considered part of these kids' care teams? And the answer is yes, right? Like, we're part of everybody's care plan. I know maybe that our primaries haven't always seen it that way, but at a certain point we encounter these people, we look at the medications that they take, we look at the history that they have, and then we make clinical decisions based off what we know about those people, and we try to treat them and get them to the emergency department where they can get reincorporated in the broader healthcare system. So absolutely, we are a part of these patients' lives. And so especially as we can include more information that filters down to us, the better we can take care of those kids. You know, I always kind of laugh too, you know, in EMS and the emergency departments, like, we're the last healthcare professionals left who don't get to read charts before we go in to see patients, right? Like, every other doctor, every other healthcare provider is sitting there looking at it. I've even seen some of the emergency physicians with our kids, like, till the last minute, till they have to walk into that room, reading that computer on their way to go in and see that kid. And so this is a system that helps us bring us in line with that. You know, obviously we can't do that with every patient yet, unless you have one of the PCR programs where you can kind of look up histories on the way. But this gives you that information before you see that patient so that you can make better clinical decisions. Treat and no transport. So it's becoming more and more of a thing. Like, these kids are complicated, right? And you can only imagine how hard it is on them to go be readmitted to the hospital where they are exposed to every other bad bug, virus, bacteria that is in that hospital. And some of them are pretty fragile. And then, you know, if they catch an infection while they're in the hospital, then their clinical stay is extended that much longer. And so if we can appropriately treat them at their home for what's going on with them that day, and then help them stay there, or help them stay there long enough to get in to see their specialist without having to go through the ER or ICU system, then maybe we can help that patient have a better clinical outcome. And then also avoid some of the unnecessary risks of transport. We try to think about that, right? But I mean, there's still a risk each and every time we get transported in an ambulance, and especially a helicopter. So if we can maybe mitigate risks and do things in a more controlled fashion, we can help our patients out a little bit more. On that same note, we find that we have a good place to tie in with community paramedic programs, community paramedic programs where they're seeing these patients beforehand. Let's see if we can prevent emergencies before they ever happen. Let's see if we can prevent unnecessary transports. Let's make sure that we have access to all the resources that we need for that kid, so that they can have a good outcome. Right. And some more things for the future. You know, as I said, we're trying to centralize a lot of things through the database. You know, it doesn't, you know, I know it's hard on our coordinators to be out there, and if they have to come up with all of their own proprietary training systems or their own information, and, you know, that's hard on them. I certainly hope that they do some of their own training, and I would love for them to share with me, because whatever we can share throughout the system, it is a community, right? But we will try to use the database to centralize some of the training so that and resources are available for everybody to use centrally. We have some future developments we're working on as far as ease of getting to the information to people, and that's something everybody's always worried, right? Like, we exist in this 911 system where the tones drop. I got a policy that says I got 2 minutes to get to my truck, 3 till wheels are rolling. Trying to do all this stuff. I'm trying to get to the call. I'm trying to navigate it, and I got to look up a chart too. Which, first of all, I'd argue that that's going to help the rest of your call go better. So it might still be worth 30 seconds of your time. But we want to make sure the information is getting out, because we know that if there's any frustrations, how quickly. I mean, I've been there. I rode those seats. Like, something's not going right. Your map book's not right. Like, you're just ready to toss the darn thing out the window, right? And so we're working on coming up with systems where the information gets pushed to medics, and especially from dispatch side. And you know, EMS, I'm happy to report, is doing very well, and I'm glad to see a kind of almost a homogenization. Like, people are kind of coming together with a lot of their different policies. You want to talk about a place where there is a wide variance in capability. includes dispatch. Now, it's not to knock dispatch. I get that it came from different places, but we've seen everything from a cutting edge. We can drop PDFs to people to like we've gone to teach at places where somebody like still picks up a rotary phone and answers the phone and says, like takes their cigarette out and says, oh, somebody will be there. And like,
Cats and smoke.
yeah, oh yeah, definitely cats walking around their feet and like, oh, we'll get somebody to you in 7 or 27 minutes, and then they hang up. And so there's a broad variation there. But as the technology develops, we really think that there's the ability to maybe even push the plans to crews as they're going on the calls. Something else we get a lot of feedback on for a future concept on that idea is the idea of QR codes. Even if you can't get the information onto the way to the call, if you were to show up and see a kid and they got a big fancy tag and there's a QR code, you could scan that code and the information would come to you right there on a smartphone. So especially for travel, we help some of our kids who travel pretty far and all the time, we'll call Florida ahead for them and we'll call, Walt Disney or Orlando or wherever they are and be like, so we got one of our kids that's coming to see you and let us tell you what all that entails. And usually that like leads to several like, oh, you need to talk to my boss about that. And we'll like eventually get up somewhere there and talk to them. But we do get the idea that like, okay, well, what if we could just have that QR code where somebody could scan the kid, receive all their information in real time. We'll continue to capture numbers and metrics and data, and I've already kind of touched on that, but ways, first of all, to report what we're doing, but I think also we will find in those numbers ways to improve what we are doing, and that comes back to feedback systems, both to improve STARS, but I would also argue to improve the healthcare system as a whole. As Trish has pointed out, like nobody's tracked stats on that, and the problem with that is that if you're not tracking data and you're not seeing how you can get better, you're just shooting in the dark. And so the idea that if we can maybe see more what's going on with this population, we can better improve the way that kids are taken care of out of pediatric hospitals. All right, so that is our presentation. There's our contact info. I think we're gonna end just a couple minutes early, but we'll stand up here gladly if you guys want to come up and talk to us, if you have any questions. We always love feedback.
So please feel free to follow us on, oh, if they want to go back.
Oh, so sorry. One time I fly through a slide.
I know social media gets out of hand. In fact, I have months where I shut it down for my personal pages, but our Instagram pages and our Facebook pages actually has quite a bit of information on it. You'll keep up with stories and pictures and things that we're doing new with the program. Again, I like to tell stories about my kids. I'm a storyteller. That's Sean. He's actually one of our success stories. Just to give an example of where STARS can actually make a difference. I mentioned that death we had in the school system. We had a paramedic crew who we had trained who went to a 911 call for a cardiac arrest at an elementary school, and unfortunately it was a child who had a completely obstructed upper airway whose trach had plugged. It kills me because she had made it from the playground. She had a good prognosis overall. She had walked from the playground to the nurse's office complaining of shortness of breath to where she eventually arrested. Her regular nurse was not there. The school nurse was not trained in emergency trach care, only suctioning. Suctioning didn't work. EMS got there. Long story short, they knew what to do. They recognized the obstruction right away, changed out the trach, but compressions had already been started. They got Ross back after one dose of Epi, and they were so excited, but the anoxic injury was too great. She herniated and died. This very same crew then, a year later, got to run one of our STARS patients who was an accidental decannulation. Mom was great, but this isn't a one-person job. She changed his trach, hadn't realized that he immediately decannulated right afterwards, and it was curled up underneath his trach sponge. They immediately went to take a look, said, holy cow, he's decannulated. Where's your smaller trach? Because they knew from training, got it back in, and he went from near death to, that was a week later. They transported him just because they were afraid he would have aspirated, and we actually sent him home about 4 hours later after observing him. And so he's actually saw him in the hallway last week. He's off of his vent completely and just running around with his trach, and he's hopefully going to be decannulated. So we're hoping if this is a success story, this is what can happen. He's going to be okay. It was just a preemie who needed some time to develop. So that's another one of our
One Kid Counts, Stars Matter stories. So again, we're here. Any questions you have about the program or implementing the program, we're here to help. Like I said, we're not car salesmen. We don't get any benefit off of selling the database. It doesn't get sold. It's for free. So, yeah, anything we can help you with.
So you all do help other districts get this thing started?
Absolutely, yes.
Yeah, and I think a key thing she said there, but it's free TMS, it's free to emergency departments who are gonna access it for emergency care for our kids. Like, it's just a program we want everybody to use to help take better care of sick kids.
And we travel, so we go, especially for a high-risk child that's been identified, you know, we'll always, sometimes if you don't have a kid in place and you just want to start as a district, we'll make it out to you. But if you identify a high-risk kid, we'll travel. We've traveled 2 hours and more just to do an introductory training to STARS and help with the process of enrollment and all that. So, and we don't take just kids from Cardinal Glennon. We can take kids from any pediatric hospital home. So, yeah, we're very, very willing to help anyone. And it's fun, actually.
Yes.
So, yes.
So, I've got 6 STARS kids in my county, Shelby County. And we've done a modified, we're still using the binder. Kind of broke contact with you a couple years ago. But if I send you their information, and some of them are Glennon kids, but if I do send you the information, I mean, would you upload that, or how does that
Absolutely.
work?
Yeah, please do. Yeah, because that's something we're trying to backtrack a lot. When you see our numbers up there, it's because we haven't been able to pull everybody who was out there via binder into that system. So we want, if you have them out there in your binders, we want to pull them into the database and get them formally in there. Because even if you guys can't get on the database right away, it protects them, it keeps that information updated and keeps the stats. And then the flights, area map has it, Arch is working on it. Most of our community hospitals are getting on it. So.
Now on that, one of my kids is autistic, very, very closed, you know, so any light or movements, just, he goes into a mania. So we've included him in our STARS program. Do you have any other of your kids that have those similar? Or?
We do, yeah, we do. You know, I have an example of that, and it's so hard for me because I've been trying to not back away from the behavioral community because I want to. We still want to really support that community. And our Knights of Columbus Center, who handles our autism community, really sends me kids constantly. Because I tell them, if you're really afraid they're going to get hurt if they're not in STARS, you know, I'll do my best. And we actually have a kid in St. Louis City, because St. Louis City was one of the areas we said absolutely not. We cannot handle the behavioral group in St. Louis City. But I had one who eloped 4 times in the middle of the night from the north side. And I'm like, he's nonverbal. And I'm like, oh, fine. So we put him in St. Louis City EMS's. Found him 3 times now and taken him home. We have his photo in it. We can do photos in the database. So he's nonverbal. We have a current photo. He's been picked up by police. They call EMS because it's a city, and they're like, we're going to dump on EMS. So they're like, oh, that's Star 26. And they call his mom. They'll get his picture. They drive him home. And I'm like, holy cow. You know, they know that they can entice him with music. They know all these things that they can do to calm him down and get him to happily go home with them. So
the only way we can is take a med device and tell him it's a flower, so he'll sniff it, he must, and directly. It's the only way we can calm him down. It works. Yeah.
But you was talking about the app. Can anybody look at this app or?
No, so we do have to do a contract with your service. It's free, but it's a business contract, and that allows us to have data sharing agreements in place. And so we'll typically do that either with, you know, like I said, the emergency department or an EMS service specifically. We can send those contracts out to anybody. I do always like to preface it with, I mean, it's the weirdest thing in the world. Like I came straight out of the back of a truck and they're like, here, take this to people, and they'll sign it. And I started reading, I was like, you want me to give paramedics what? But they kind of told us, they're like, it's a very standard data sharing business agreement. And so once you sign that, your service has signed that, that allows us to share all the information freely. And then we'll set your district up. We'll assign a coordinator. That coordinator kind of acts as a personnel manager for your district. They can put employees in, they can take them back out if they are to leave your service, and they'll kind of manage everybody from there.
Any other questions from us specifically? Thank you so much. Thank you for staying awake during the post-lunch lull. I know that's difficult, especially there's a lot of talking in the charts. I appreciate all of you coming. Thank you.
Thank you, guys.